Um, I certainly want to thank Chris and the GETA team for inviting me to present today. It truly is an honour. And I have to say that the conference has been amazing. Yesterday I tuned in at home for the live streaming of the presentations and they were phenomenal. I especially loved Montana's perspective and the dads, and you know, I have to say I found their presentations really powerful and really motivating. So thank you so much. I do hope to share just a few of my observations and I guess personal reflections, and to say that you know, I know I don't walk in your shoes, but I definitely feel I walk alongside you. Today, I'd like to just present, I guess, a little bit of insight into what the hospital journey can look like. And I know many of you have experienced this more than firsthand, to look at some of the challenges, particularly for prolonged hospitalisation, and I guess to consider some of the lessons we've learned. And I'm going to present a case today, and I thank Amy so much for her presentation because she highlighted so many things that this family have encountered on their journey. And, you know, for us, difficult epilepsy, increasing care needs, recurrent infections, difficulty managing secretions and deteriorating health have all been very challenging. So all the time trying to bolster hope and deal with hardship in hospital. So I'm reminded that this little girl turned 1 last Sunday, and it was a fairly precious milestone. I called her mum only to find out that she'd actually spent the night in the emergency department waiting for a bed on the ward. And I said to her, "Mum, how are you going?" And she said, "Well, I'm where I need to be." Never any complaints about her fatigue or how much time they spend in hospital. To quickly go through, delivery was normal for this little girl, but by day 4, she did develop seizures, and by 1 month of life, they were clearly very well established. They were multifocal, they did resolve, they were predominantly hemiclonic, affecting the right side of her body, and sometimes they would evolve to generalised tonic-clonic seizures. She did evolve to a DEE. Thank you, Amy, for that incredible explanation. I feel like I'm a little bit off the hook in having to explain. At about 4 months, she did get a genetic diagnosis of Cinjo1, and over the course of the year of her life, her seizures have certainly worsened, and she has had multiple admissions, sometimes to ICU for airway support for focal status epilepticus. The other overriding difficulty for this child is that she has had recurrent viral chest infections, and managing her secretions has become increasingly difficult. So what is Cinjo1? I'll tell you what I know. I'm pleased I've got M here in case I get stuck, but it's a homozygous pathogenic variant, which is certainly responsible for causing DEE in this little girl. She had some whole exome sequencing done, which showed premature stop codon in Cinjo1.P, and it was classified by the lab as being a pathogenic variant. I understand that the exact variant has not been previously reported, but others with loss of function variants have profound intellectual disability and ongoing seizures which are difficult to control. And I think that certainly fits the story for this little girl. What we know is that it's an important gene for synaptic transmission and vesicle recycling. So where does that leave this little child? We do have progressive deterioration in her development. We have definitely a pattern of very prolonged focal seizures that occur about every 2 days, extremely challenging, and they're very refractory and very hard to turn off. So she'll often fit for 3 to 4 hours. She's quite floppy, also quite hyperreflexic. She has visual impairment, global developmental delay, and as mentioned, this ongoing issue with infections. We did initially treat her with the UCAS protocol, and many of you will have a good understanding of what that is. It's high-dose prednisolone, and it's used to treat infantile spasms in most instances. And in this case, she had evidence of that on her EEG with modified hypsarrhythmia, but we were attempting to prevent her from developing infantile spasms and to try and improve her development as much as we could. At this stage, she was already on 7 anti-epileptic medications. So what does that really mean? This family are of Sudanese background, so they already had very diverse cultural differences. And for Mum particularly, the experience of isolation, all of her family remain in Sudan. And she talks to me often about that loss of community and family for her. She misses it deeply, and it has had great impact on her mental health and psychological well-being. There are significant stresses for this family, as we all know. Being in hospital for long periods of time means that we have to divide our resources, and they have a little 4-year-old son, and because of COVID we have one parent at the hospital and Dad's unable to work. He has to look after their other sibling. I'm sure that's a familiar sounding story for many people here today. The challenge of her refractory seizures has made discharge planning very, very difficult. As time has progressed, she's required intermittent suction, so there's need for portable suction at home or whenever they're out and about. She has intermittent need for oxygenation, and therefore we need to monitor what her oxygen levels are. So that's already a few different additions to her care that we have to consider. And we need a very watertight emergency rescue plan for the family at home, because it's sure very complicated in hospital. Discharge planning for everybody takes a fair bit of commitment, and we have in this case a very lovely neurologist and an incredible team of people that work towards this goal. There were a lot of family meetings and they were done with an interpreter, because whilst Mum and Dad had quite good spoken English, their receptive language at times was challenged. Mum really taught herself all the English that she knows, and at times when we were having medical discussions it would become really complicated. So wherever possible we did try and use an interpreter. Social work was invaluable because there were a lot of NDIS pathways to navigate. You'll all be very familiar with those difficulties and challenges. And one of the main issues for the family is their current housing, which is quite unsuitable. They live in a unit which is on a 4th level and there's no elevator access. They have to actually carry everything and all the equipment up the stairs to get into their unit. So we're looking and trying to help with having more suitable accommodation arranged. Provision of the emergency plan and education was done in stages, broken down so that they could clearly understand what they needed to do when they finally got home. In addition, we had to provide education around safe storage of oxygen, and our amazing senior physiotherapist met with this little girl every day as part of her treatment. So they spent a lot of time with Mum and Dad making sure that they felt upskilled and confident to carry out those activities. It would be naive to think that you can go from 2 or 3 months in hospital to going home and not having any challenges. So we do try and stage that preparation. And in this case, we have a model which you may be familiar with called Care by Parent, where we try and support the families, but actually have them doing as much of the tasks that they need to do to care for their child in the hospital setting, so that if they need assistance, we can provide that. And then we followed up with what is called virtual hospital or hospital in the home. And that was a really great way to support the family. Someone from the nursing team would go out for an hour every day, make sure that Mum and Dad were confident with the equipment, that they didn't have any troubleshooting issues or concerns. And that was a real support to the family. And we really have tried hard to link in with the local paediatrician or local hospital. Although her high needs are really too much for them to manage, they're still an integral part of her team. I just wanted to spend a few moments on the seizure management and emergency medication plan for this child, because I think we all can appreciate for children with DEE, it really is a level above in terms of complexity. So this family were obviously very au fait with how to manage focal seizures. They knew when to call an ambulance, but there were additional safety challenges based on I guess, the growing complexity of her care. And I was really fascinated by your mention of co-sleeping, Amy. This was something that we encountered with this family, and I was really surprised by your research and the overall numbers for that. We were aware this family did co-sleep, but we had to, as time progressed, think about how we could sensitively discuss taking her home and somehow managing, a feeding tube for a nasogastric feeds, where we're going to place the oxygen, how we're going to safely stow the oxygen when we've got 4 people sleeping in one bed. We know that there is risk with entanglement. We have to consider that. And we also have to bear in mind that she's really floppy and she doesn't have great tone. So after a lot of discussion, we realised that we could reconfigure the room. We could take out some of the furnishings. We could bring in an additional bed so that the parents could sleep alongside her. And then if an alarm went off or they needed to, intervene in any way, they could do so, but they were still there. It was difficult, but they understood. And I think we navigated that challenging conversation quite well. So I guess the key points for this family and for others is that it's not a garden variety emergency plan. It's quite complicated. We did teach the family how to give midazolam, and in addition, they would go on and give phenobarbital and phenytoin via the nasogastric tube. Of course, they knew when to call an ambulance, and that's always recommended when you're giving an emergency drug. And we did try and improve their CPR skills, just because potentially the likelihood of something going wrong at home, frankly, is very high. I just thought I'd take a few minutes. We do have a beautiful video on midazolam administration on our website, and I thought it was poignant because a lot of, as I've said, instruction does get lost in translation. So I thought just to share this, this visual video really helped this family. So just have a couple of minutes. Thanks.
Not the strain of childhood or place anything in the this becomes the plastic application. You'll have to prescribe dose into the mouth syringe. Check method before administration. Avoid ever if friction should occur. Avoid live facts which are difficult to handle in an emergency situation. Eliminate secretions from the body straight. This means making sure that there is little saliva and circulating electricity. You can gently stroke the child's cheek to help remove secretion or use midazolam. To give, insert the syringe proceeding inside of the molecule and the tip. Gently syringe with prescribed amount of fluid. If the adult contains the child's exact dose, gently squeeze the adult into solution. If some of the dose is lost, do not reuse. Most drains turn off the right and ensure to whether the attendant having a policy or any other treatment professionals which you have given midazolam and the dose. Until they take this into consideration, if further medication is required. Following the prescription, the child needs to remain in the covering position. This means lying the child on their side at the top of their bed to prevent them rolling forward. Then you start players have a seizure first aid poster, demonstrating the recovering position. Stay with your child and observe their breathing. Check that their chest is rising and that you can feel warm air being expired.
So we'll leave it there, but it will then highlight the key messages. And I think this was really a great resource and tool for someone where English was not their first language, and we needed to be very clear we're giving an emergency medicine. So quite helpful. We recommend CPR, obviously very challenging for parents to leave the hospital environment when they're the primary carer. So another fabulous resource is this online CPR for families, which is attached to Kids Health website. It's not an accredited course, but it's about 90 minutes of modules that will take you through videos. And it's very great as a refresher and to make sure that, you know, parents have the skills they need. As time went on, we actually did omit the midazolam for this family because her respiratory deterioration was such that it just wasn't safe for them to do that at home. So we added in another drug, and essentially for this little child, it would be phenytoin at 30 minutes, it would be phenobarbital if the seizures kept going at an hour, and then we added lacosamide. And at that point, they knew they needed to call an ambulance if she was still fitting, and they would contact the neurology team here for further advice. So quite complicated. And it fails, truthfully, more often than not. So I wanted to touch just at this point on seizure monitoring devices. I think you will all out there have a fair, familiar understanding of what is available. And for this family, we really did need to think about the importance of what sort of monitoring would be right for her at home. There are many devices, as you know. There's a mattress sensor which fits on top of the mattress and picks up seizure-like movement. It's TGA approved and really designed for children over about 16 kilos. There's the wearable technology for teenagers particularly, but for anybody, which will pick up nighttime movement, which is a bit stereotypical of seizures and change in heart rate. It's TGA approved. Then you have the, you know, the infrared cameras, the SAMI alert monitor, which are not a medical device, but they are quite popular amongst families for picking up nocturnal events, and they can be paired back with smart devices. So they're quite popular. The night watch, which is quite popular among families with children who have some disability or autism. It's comfortable. The children tend to leave it on, and there have been some studies done in the Netherlands on that one. There are many devices out there, suffice to say. It comes up a lot. I will always direct people to Epilepsy Foundation or one of the other community organisations to do their research, and then encourage them to have a discussion with their doctor about what fits their family and their lifestyle. And important to know that the ILAE did look into all of the devices, or many of the devices that were available, and published their research in epilepsy in 2020. And what they found was that there was a high level evidence for accuracy of automated detection of generalised tonic-clonic seizures or focal to bilateral tonic-clonic seizures, that wearable automated seizure detection devices are recommended for select patients as a clinical adjunct, that clinically validated devices for automated detection in unsupervised patients is recommended when alarms can result in rapid intervention. So in other words, if having a device means that you get there and you can position your child and support their breathing, then they're considered to have good utility. They're not currently recommended for other seizure types, and further research is obviously needed to improve performance and clinical utility. There are some other great papers that I've attached the links to at the end, but I think that's a good overview. For this little girl, given her need for oxygen, suction, we did feel she needed a medical grade device, so she went home with an oximeter. It was pretty hard to source. Yet those of you who know the costing, they're not floating around in the hospital or anywhere else, but we managed to borrow one for them to go home. And I guess at this point, just to really tie together some reflections on the hospital journey, for this family, there were definitely some difficulties around language and communication, which we tried very hard to address. When I talk about mixed messages, I think I'm talking to the fact that a child with this many needs has many different teams. We have sleep, we have a paediatrician, we have a neurologist, we have allied health, we have social work, so on and so forth. And it's just like white noise when you're so tired in hospital, just trying to make sense of all those messages is really difficult. And I'm yet to meet two nurses that do anything exactly the same. So confusing. Loss of structure and routine, the physical fatigue and sleep deprivation with long hospital stay, with one night, but long hospital stay. So challenging. And for this mum, it would often impact her memory. She would really struggle to remember the things that were important to her, I should say, on any given day. And of course, COVID has just put a whole new dimension to what we mean by lack of flexibility in hospital. We still only have one parent at the moment, and that's a long road when you're in there every day on your own, as many of you will know. So we tried in this case to overcome some of these challenges by allowing mum to have some input into what the daily routine for her little girl looked like. She loved the whiteboard. She would write down little notes in Arabic or notes in English, because when she woke the next morning, as I said, she was so foggy, she just couldn't think of the things that were really relevant for her to discuss. We did encourage her to schedule in some breaks for herself and her child in terms of the care being delivered. And I talk about red light, green light. What I mean is having the power to be able to say, I can't have all of these visits today. I'm just not having a good day. I haven't had enough sleep to manage that, and I need some space. So quite often this mum would close the door, she'd pull the screens, she'd roll over and she'd have a sleep. And we all knew that that was her time. And if we needed to bother her, we'd wait till the curtains came open, and unless it was urgent, we allowed her to have some rest. Improving the hospital stay, well, I think she did a very fine job of communicating her concerns to the team, trying to offset all the anxiety associated with having a child of this complexity with all the needs that she has, seeking clarification and accurate information as you go along. And she would often provide input at the nursing handover at the bedside. You know, we really tried to empower her to have that input, because she, like all of you, know most about your child, and that was as valuable to the nurses as it was to her. Using all the supports available, we talked about many of them, and having a really watertight discharge plan and follow-up. That's important for everybody, but especially for families like this. I mentioned hospital in the home. It was fantastic. Look, the road has been rocky. There have been multiple readmissions to hospital, sometimes because the seizures didn't stop, sometimes because of a respiratory exacerbation, and increasingly because of her DEE. She's really drowsy and really sleepy, and that has been the latest reason for coming back to hospital. Just one thing to share with you. Last week I had a call from the mum to say, I've run out of Dilantin and she's fitting. And I thought, great, I've just done a fabulous job in preparing discharge. So the fellow and I called all of the local pharmacies to see if we could get hold of liquid Dilantin. None of them had it on the shelf. So the default is always to go back to the hospital pharmacist and say, we're in a bind, can you put some together? And of course they did. But to their credit, our amazing pharmacist said, how are we going to stop this from happening in the future? So she put together this pictorial of all the medicines for mum, and she divided it into the ones that she needed to order from the hospital pharmacy and those that she needed to order from the local pharmacy. And mum would stumble on the generic names and she'd get confused on the phone. So this was amazing because it enabled her to know and have control over what they look like and the ordering process, and hopefully moving forward we won't have difficulties. So just very quickly to summarise, what does a year of her life look like? She's had 11 emergency presentations just here at Sydney Children's, 8 inpatient admissions, multiple investigations and procedures, and adding it all up, almost 5 months in hospital. And that is not to include the local admissions or presentations at her peripheral hospital. It's a lot of time spent here. But we did get there. This is our beautiful family, and you can see amidst all the uncertainty, there is an enormous amount of joy. Our family observed Ramadan in hospital, and this was actually the end of the 1 month of Ramadan, and they were going home to celebrate Eid with their family. So there were all sorts of joys around that, and it is not to say it's not still a difficult journey, it absolutely is, but we definitely have great moments of joy, and they fiercely advocate for her and love her dearly. And I'm so grateful that they trusted me to share this story with you today. They know that they're in safe hands. So thank you very much. And I hope that leads in beautifully to what will follow with the presentations. Thank you so much for sharing that with me.